Okay, welcome, ladies and gentlemen, to the Foundation Group board meeting of all four boards and the first one of 2024 calendar year. I want to, just before we get going with the formal business, put on public record the sad loss of one of our much loved colleagues in the George Eliot, Winston Crustow, who is one of our clinical directors. Winston, we lost Winston and his family lost Winston a few weeks ago, and Winston was a very, very special colleague for us all to have and will be greatly missed, obviously, particularly by his family, but I know by everyone at the George Eliot. So Winston and his family, I hope you feel the love and affection that you all have for him. 0, 2, 0, 4, 5, 8, 7, 0. Apologies for that. So we do have formal apologies from some colleagues, from Simone Jordan, Katie Osmond. Katie, I know, is now home after an illness. And Katie, we hope you're feeling a bit better. And Susie, thank you for joining us, standing in, and what you're doing on a daily basis, standing in for Katie. And we have apologies from Barty as well. And I know Helen Lancaster will be joining us a bit late. Any new declarations of interest, colleagues? Please raise a digital hand. Hack?
I've been appointed as a non-executive director of Innovate.
Well, that sounds rather wonderful, Hack. Thank you for doing that. Any other declarations of interest? Okay, we'll duly note that, Hack. Thank you for doing that. Julie?
Well, I don't know. I think I've done it to the Worcester board, but I'm the chair of Health Data Research UK, and I don't know if you've got to do it in both places. So,
okay, better safe than sorry. Thank you for that, Julie. That will be appropriately noted as well. So we'll just do some of the formal minutes of the meeting held on the 1st of November. The George Eliot minutes of the meeting held on the 1st of November 2023. For George Eliot colleagues, if you're not happy with the accuracy of those minutes, could you please raise a digital hand for me, please? Okay, I can't see a digital hand raised, so I'll take those as an accurate record and duly sign them. In a similar way, Swift colleagues, the meeting held on the 1st of November, if you weren't happy with the accuracy of those minutes, Swift colleagues, could you please raise a digital hand? Again, I can't see a digital hand raised, so I'll take those as an accurate record. For Worcestershire Acute colleagues, those minutes of the 1st of November, if you're unhappy with them, could one of you please raise a digital hand? Okay, I'll take that as a appropriate approval. And then finally, Wye Valley colleagues, that meeting on the 1st of November, if you weren't happy with the accuracy, could you please raise a digital hand? Again, I can't see a digital hand raised, so I'll take those as an accurate record. So we'll move on then to matters arising and the actions report, which is on page 69 of 183 in my pack. And the first point was on the performance report, the managing directors to ensure analysis takes place to compare cancer diagnosis from ED attendance across each trust. Now, I understand that's been done, but there's it's sort of still ongoing work. Jane, Adam, Catherine or Stephen, is there anything you want to add to that action point? Jane?
I actually saw the data yesterday, so it's just come through.
Okay, super. So if we can bring that to the next meeting, that would be great. Thank you, Jane. And then we had the deep dive into additional performance measures, in particular theatre productivity, and my Chief Operating Officer colleagues were going to look at this. Is that still ongoing, Harkamel, Robin, Andy, Helen? One of you can talk to me, that would be wonderful. Andy?
Yeah, it's still work ongoing, Russell. We'll aim to get it for next time.
Okay, super. Thank you very much. Andy, that's a very clever trick. I mention your name and Harknell's voice comes out. And then we had the Gender Pay Gap Annual Report, and my Chief People Officer colleagues were going to include a detailed breakdown on the female-male gap, and from across each division, across the 9 protected characteristics as well. So I assume that's ongoing also, colleagues.
That's complete, Chair. So I did send through an update, but it must have not been transposed across, but we have shared those in individual organisations, so it's complete.
Okay, super. Thank you very much. Just for members of the public, we've had an interesting workshop meeting this morning. In particular, we had a large session, which was our cyber security training, which we need to do as individual boards. Again, it illustrated the enormous problem and challenge of cybersecurity. Just to put cyber theft in some context, because it did amaze me, the annual theft due to cyber activity across the world is over $8 trillion a year. To put that into some context, that is twice the size of the German economy. So the level of theft going on through cyber activity is absolutely enormous. So if there was one thing I would suggest to members of the public to protect yourself, is if it sounds too good to be true, it almost certainly is. If it's an email, if you don't recognize an email, delete it and change your passwords frequently and make them complicated. We then had a session on the South Midlands Pathology Network, which is developing and which we are partners of. That was very interesting, led by Neil Anderson, who's the system lead on that. Lots of work ongoing behind the scenes, and we are endeavouring through that work to ensure that our citizens get more comprehensive, higher quality pathology tests, faster than otherwise they would, and at better value for taxpayers. And then finally, we had Lord Patrick Carter join us to talk more generally about productivity. So an interesting session overall. And he was very complimentary about the foundation group and the work we're doing to try and identify and share best practice at pace. And again, for members of the public who may be interested, Glenn was interviewed by the HSJ, the Trade Journal, on the future development of groups. And so if you've got a spare 25 minutes, listening to the dulcet tones of our group chief executive would be a worthwhile endeavour, because Glenn talks about the future of groups in the NHS. So, Glenn, is there anything you wanted to add to my overview of the workshops?
No, you covered it really well, Chairman.
Okay, great. Thank you very much. So we'll move on then to the performance review and updates. And firstly, the Foundation Group performance report, which is going to be covered off by the managing directors. And I assume we'll be doing this in the order of the performance report. So, Jane, over to you.
What we planned, Russell. I'm going to talk about 3 areas. An area of concern, an area of an improvement, and an area of pride for us. So the area of concern, I guess, continues to be our emergency department performance, but what that really means in terms of congestion. So the actual performance is, for December, in the data that's there, is about average nationally. Last week it was top 3rd in the region and nationally. But that really just tells you that everybody is in some difficulties. That said, we had a CQC, an unannounced CQC inspection on the 5th, 6th, 7th and 20th of December. And that'll be published in a few weeks' time. But that raised some serious concerns about safety, and a congested ED is not a safe ED. So I guess I just want to give just a little bit of context about that. So our ED, in many ways, has been the subject of continuous redesign ever since COVID, both its processes, its pathways, and its environment and the footprint that it covers. And I think what the CQC saw was that the planned pathway just doesn't work consistently enough in a congested department. So we've obviously responded to those safety issues, partly by increasing our staffing level, and that is at premium cost, and Lucy will come to that later in the staffing report, but also some operational digital dashboards that were already in production as part of that continuous redesign, but those are now implemented, which gives a live view of some of those safety issues of how many patients are waiting for triage, how many have got a high news score. But the root cause of that doesn't belong in the emergency department; it lies outside that. And we had a summit with our senior clinical teams and senior managers on Monday of this week, just looking at the analysis of why have we gone since pre-COVID to now to having probably a 20-bed deficit to probably something that's nearer a 60-bed deficit on a day-to-day basis. And there are three real drivers of that. The first is a growth in demand. So we've got 8 admissions more per day. Many of those managed through same-day emergency care, but 8 more admissions a day. A growth in length of stay of around 0.6 of a day, which drives quite a large number of beds. And then our medically fit for discharge cohort has changed significantly over that time as well, and has about doubled and is part of the length of stay increase. So the things we're prioritising, and we'll go through this at some detail at the Wye Valley Board in March, are really industrialising our virtual ward. So really making that work and getting from the prototype we have now into something which is much more significant. Simplifying the access into our community services. Too many people don't know how it works. Maximising SDEC. And then working with our colleagues, particularly around the Better Care Fund, on discharge to assess pathways to unblock that back door. And then on top of that, and I know Glenn's quite keen that we do this as a group, just looking at that broader demand and capacity analysis, that once we've done all the things that we can do, there's a best in class, then what does that mean in terms of what our acute bed requirement needs to be? And so that's some longer term work that we'll be doing. So that's the concern and what we're doing about it. In terms of improvement, our faster diagnostics standard has improved from the data that you've got. It was at 73% in December and has maintained that in January. So that's getting up to and just above national average now. So that's good news. It will feed through into improvement in 62-day treatment for cancers, and we are currently average nationally on that, and just best in the group. And then the last area is an area of pride, which I think is around our mortality statistics, which have really held up. And again, they remain the best in the group. And so despite that ED challenge, despite the level of boarding that's going on and the congestion that we've got in the hospital, and there's a real focus on early access to treatment in ED, maintaining standards of care in some difficult environments on boarded wards, and also that systematic approach to mortality outliers that's done through Chizo's team. I'd raise just one note of caution on that, which is when the same-day emergency care coding changes in April for us, but nationally mandated from June, it will do some strange things to our mortality figures. So we can expect them to change and do some odd things, I think, probably over the next 6 to 12 months. So that was my update, Russell.
Very good. Thank you, Jane. And thank you for leading all of that very important work on flow. As we all know, across the Foundation Group, getting the flow right allows us to free up the EDs and to ensure that patients' time in hospital is minimised. And I just, for members of the public, I can't emphasise enough, home is best. Being in hospital when you don't need to be in hospital in the acute setting leads to hospital-acquired functional decline. Hospital is not the best setting for most of your healthcare. Home is best. and Jane, the work you're doing, particularly on virtual wards, is fantastic. Any questions or perspectives to Jane before I move on to Adam? Julie?
I just wondered, just in another setting elsewhere, understanding the data around each element of this has been really useful. So do you have the data to show part of this?
Julie, I apologise, but you totally broke up and neither Jane or I could hear you. Could you just pop it into the chat box for me? Not sure what happened there. Don't you just love technology? Julie's frozen on my screen. Any other questions to Jane? Okay, so we'll move on to Adam. And Julie, if you could pop it into the chat box, I'll make sure it's addressed. Sorry, Richard. If we can put hands up quickly, it just helps me with the flow. Richard?
Yeah, I thought I put my question in the chat, but the question is, can Jane talk a little bit about what it takes to further scale the virtual ward? Be really great.
Yes, so I think mainly it's around getting it out across all specialties. Surgery, orthopedics, so getting all of our specialties involved. And at the moment, we're really just piloted across acute medicine and frailty. So we need to get it across all of our specialties, but also link it more effectively to our community urgent response team, and make sure that we've got the right clinical advice at the right point in patient pathways. In fact, we had a fantastic meeting with Jyoti Napani this morning. Some of that national learning that she brings back, and she gave us a few more ideas this morning. So we'll be continuing to work with Jyoti.
Okay, and thank you, Richard. Glenn, Umar, can you pop your question into the chat box for me, just because of time?
Yeah, thank you, Russ. I just wanted to come in on that point. And this follows on from a conversation we had with one of the national UEC leads visiting Worcester. There was some recent analysis in the Health Service Journal, actually, which showed that virtual wards may be not as cost effective, but actually it is because of the scaling issue that Richard's highlighted there. And I think one of the suggestions is, rather than doing this a specialty at a time, as Jane implies, is actually to use virtual ward as a way of getting all patients home first more rapidly, so that all specialties or all wards have a cohort of patients that they're managing in the community to facilitate that earlier discharge, which I think would improve outcomes. So that's a model certainly worth looking at. And me personally, I feel that there is a big opportunity to do more on virtual wards, and also on using that capacity to avoid admission in the first place.
No, absolutely, Glenn. Jane, a series of points in the chat box. If you can have a look at those, it would be super. Moving on to you then, Adam. Adam?
Thank you, Russell. 3 points from Swift as well. And again, I'm going to start with ED as an area of challenge. So we have had a tough winter, I know, as we all have. And so we've seen a drop in ED performance, both in terms of 4-hour performance and ambulance handover during the last few months. That said, we still are above the national average, particularly for type 1 attendances. I think the challenges we've seen are high attendances, the number through the door, particularly high out of area activity, generally from the Coventry and Birmingham and Solihull areas. We have high levels of intelligent conveyancing, and actually around 20% of our ambulance activity is out of area IC on average. Occupancy has also been very high, which has clearly contributed to some of the challenges in ED with flow. That said, I think it's encouraging that despite experiencing the pressures that are probably worse than year, we've been in a better position and at a better level of performance across the winter than we were last year, which I really think highlights some of the work that's gone on in ED and with the ED teams. I think it's also really important to acknowledge our community teams, because they have been incredibly helpful in diverting away from ED, supporting some of that urgent care in the community, and I think that's been reflected through the intention to award the lead provider for the new community integrator service in Warwickshire, which replaces the current hospital contract, and which we are working with partners and the free places in Warwickshire on, and will be an area of real focus for the coming months and years. In terms of other areas, I think it's important to note cancer. So there's been some really good work on sustaining performance with the 28-day faster diagnosis standard, which is now above target and has significantly improved across the year. And I think it's important to note that in a context of sustained and substantially higher 2-week wait referrals. We still continue to work in the system on the referral to treatment standards, and work is going on across Coventry and Warwickshire on that, and it remains an area of focus that we are keeping really close to. Finally, a point to celebrate, I want to acknowledge the great work of our theatres and endoscopy ENT teams for sustained and increased theatre utilisation. And I think we've seen some really good work there. I think particularly around the Vanguard Theatre we've had on site. There's been some really positive comments about that and the work they've done. So I want to acknowledge and thank those teams.
Thank you very much, Adam. Any questions or perspectives to Adam? Sue Whelan-Tracy?
Yeah, thanks, Adam. This might be one for Fiona. I'm continuing to pick up information suggesting that there are safety concerns for patients from the South Warwickshire area awaiting their first oncology appointment. I am aware that work's underway across the system by all sorts of colleagues to try and resolve this, but is there any assurance that Swift has raised this matter and had a discussion with the CQC given the safety concerns? Thank you.
Thanks, Sue. Adam?
So I think a few things to say there. Firstly, Sue, and I will hand over to Fiona. So this does remain an area of concern and an area of focus for the work that's going on in the Coventry and Warwickshire system. We're not seeing some of those issues come up through complaints, but that doesn't mean that they don't exist, and it doesn't mean that it's not an area of focus. We have and we maintain dialogue with the CQC over cancer performance and cancer issues, and I will just hand over to Fiona to add a bit more there.
Yeah, thank you. So Sue, there's two ways that we feed through into CQC. We meet with them on a monthly basis as an informal engagement, and I have shared our concerns about oncology there. But there's a more formal and minuted meeting, which is the system review, quality review meeting, which is monthly, which is chaired by the ICB, but has Health Watch and CQC in there. And I have repeatedly raised my concerns about Swift, but also about the ICB and system concerns around oncology there. So they are well cited on it and are supporting us in those conversations.
Okay, thank you, Sue. Thank you, Fiona and Adam. Any other questions to Adam? Okay, we'll move on then to Catherine. Catherine, over to you.
Thank you very much, Russell. So I too will start in the emergency department. In December, the 4-hour performance was 73.4%. And as everybody is saying, it is very challenging for emergency departments. Nationally, the figure in December, the average performance was 69%. So the team did well in December. I think I need to say to colleagues at George Elliott's board that you can expect that number to deteriorate in January, or certainly around things like ambulance delays. And I'd like to apologise for people, because for the last 2 weeks in particular, we have had considerable high number of patients needing admission to hospital and real pressure in the emergency department. And I'd like to say a huge thank you to our teams who are working so hard in order to provide safe care in really challenged circumstances. So I think we should be proud of that figure, but it's very difficult. And I think you can see on our bed occupancy from December at 93%, that's rather flattering. We had a good Christmas effect with lots of people wanting to go home to be with their families for Christmas. But as you can see, year to date, our occupancy level has been over 98%, which really means that we've got no additional spare capacity to go into. In terms of our mortality figures on here, our shimmy in the month of in the 12 months between August and July 2023 was 118, which is higher than expected. The next reporting period, that number falls again back into the expected range. So it's a little unclear why that month in particular has been higher than expected. We have been doing some work around coding, which has quite an important effect on the mortality figure. And we're monitoring that work through the Quality Assurance Committee. But the next reporting period, I'm pleased to say that's back in the expected range. Sickness, we have picked that up before. The last time we were in the full boards, George Eliot was the worst in the group. I think you can see there's been fluctuation and those numbers go up and down. But last year, for the same reporting period, the figure was 6.6%. So that is quite a significant reduction for us. And I think the work is ongoing to support colleagues to return to work and to look after them so that they don't become sick in the first place. In terms of cancer performance, that is probably our biggest area of concern at the moment, notwithstanding the pressures in the emergency department. The faster diagnostic standard was affected significantly in December. Two reasons in particular: fragility in the urology workforce, and thank you to colleagues from Swift for their support over some help around that. And the second area was a high number of 2-week wait referrals in breast cancer. And I'd like to say thank you to colleagues in UHCW for their support, helping us to see those patients. So the faster diagnostic standard is improved into the 70% for the next couple of months, and we are aiming to get to 75% in March, which is the required standard nationally. I think we're not making such great progress on the number of patients waiting 62 days for treatment, and that is some close works going on in that to understand what are the things that we can address ourselves and where do we need to work with partners where we are reliant on another centre to deliver some of those cancer treatments. Finally, on elective performance, continuing to make good progress. As you'll see, no people over 78 weeks. We've got 49 people at the end of January over 65 weeks and 376 patients over 52 weeks. So really working hard to keep those numbers of long waiters down. Just to note, you can see in a number of us that RTT position is slipping a little bit. It's on a downward trend. So it becomes harder and harder as you work through the long waiters to work on the overall waiting list. But despite the huge emergency pressures, the teams have done well in terms of managing to maintain elective work in January and into February. So I'd like to commend them for juggling so many things at one time. Thanks very much, Russell.
No, thank you, Catherine. Thank you for your leadership and the comprehensive overview. Questions and perspectives to Catherine. Umar?
Thank you, Catherine, and first of all, well done on to yourself and the team. Having had to use ED, not George Eliot, over the Christmas period, I can understand the pressures that were there. I've never seen anything like it in my life, to be honest with you. It was a bit like a war zone. So thank you for that. Just a quick question on the mortality rates. Are we monitoring by disproportionality in terms of certain communities who potentially are at risk of higher mortality in those particular communities? I'm just wanting to get an idea whether we are keeping a kind of eye on that type of information, considering we are, focusing ourselves on health inequalities and prevention and going forward. I just think it's really important that we just have one lens on that part, because what we want to be doing is making sure that we can try and tackle some of those issues as they're coming along. It's just a general question on that point.
Yeah, so there's two measures of mortality, Umar, and I haven't got time, Russell hasn't got time for me to go into the technicalities of both, but HSMR and SHIMI is the one that we're talking about here. They do take into account deprivation, and they try and match age, take into account things like age, the number of comorbidities a patient has, and these things, that's why the coding is so important, because that predicts whether or not you are expected to die of something or not expected to die, and that's what gives us the overall figure. So deprivation is certainly part of that measure.
Okay, thank you, Umar. Thank you, Catherine. Umar, if you want to understand in a bit more detail, I'm sure if you reach out to Catherine or Naj, they'll be able to sort something out. Last but not least, then we move on to Stephen and Worcestershire. Stephen, over to you.
Yeah, thanks. Similar vein, I'll start with urgent care and follow on to the others. So in terms of urgent care, one thing that we have developed over the winter period that has been really successful and we're looking to build on with community partners is our single point of access. So that's one of our strategies really around helping our same-day emergency care departments grow and see the numbers that they need to see. So that is one that we are keeping a close eye on, be able to feed back. Particular focus is on long waits with ambulances. So our overall position on delays over an hour has improved. The issue that we are really focused on is when we have long waits, we have exceptionally long waits, and they tend to happen at weekends and out of hours. So there's a lot of work going on underpinning to improve that position. Fundamentally, the issue of flow that you raised is one that for Worcestershire is driving a lot of the metrics in the wrong way, from money, quality and performance. Underlying all of that is really the work that we're doing around a frailty model and our general medicine, and that's from bedded and our same-day emergency care as well in assessment units. So there's a significant amount of work that we're doing internally to restructure that, and Jules and I are having conversations with all our clinical colleagues about how we do that short and medium term. The next part for us, that again a lot of focus as we're a tier 1 provider, is around cancer. Generally, our specialties, other than the two that I'll mention, are performing relatively well. The two that are driving our concerns and issues are around urology, and we had commissioned an external review that we've only just recently received back, and that will form the basis of our pathway redesign really. And dermatology, which again, shout to Wye Valley colleagues, because I think this is a really good example of where the two trusts are really starting to work together around fragile services, and this is one that we've been keen to explore. So we've put in much firmer insourcing arrangements, which is driving improvement in the numbers. And then we will look at Wye Valley being the lead provider, and we're working closely on that. And there's a lot of work going into there. And then finally on elective, we have a real focus on our 78-week risk. That is particularly on looking at mutual aid and internal capacity and linked to flow, making sure that we are not outlying in those areas and giving them the best opportunity, given that we've had investment in things like theatres. So making sure the productivity of those areas is the maximum it can be. That will be my summary. Russell, happy to take any questions.
No, great, thank you. And have a look at the chat box. Any questions or perspectives to Stephen? Glenn?
Mine's more of a general point rather than specific about the performance at Worcester Acute. I mean, obviously, one of the challenges at the moment is to try and ensure that we deliver on the national standard of 76% performance during March. There's quite a lot of effort going on in all of the trusts in the group on that. But this performance report has got all sorts of really useful information in terms of the comparative performance between the organisations. So I'd encourage COOs and the individual boards to take a closer look at the variation. One of the areas where the variation does appear to be quite stark links to some of our conversations that we had this morning about productivity. And one of our most expensive assets are our theatres. And if you look at that particular section of the report, there is quite big variation on theatre utilisation across group. So I would encourage the COOs to make the connections between our teams that are leading on this so that we can pull out the best practice from across the group and make sure we implement it everywhere, because that certainly getting our value out of that capacity will help our financial situation, but more importantly, allow us to deliver more improvements in our elective recovery and cancer performance.
Yeah, no, agreed, Glenn. And I think not just sharing it between the boards, but also sharing it with the senior leaders and clinical team leads, so that everyone understands the productivity differences that we're seeing. Any other questions to Stephen? Just before we move on, I'd like to apologise again to members of staff on the Worcester site for the continued problems they're having with car parking. I'm a member of the Worcestershire Acute Hospital staff group, and without mentioning her surname, I'd like to personally apologise to Kerry for losing her windscreen wiper with pretty disastrous consequences when the barrier came down the other day. So Kerry, I apologise on behalf of the problems you're having with car parking. There is a lot going on car parking behind the scenes as we try and find practical solutions, particularly with colleagues from Worcestershire County Council. But Tiffany, and I won't mention your surname, Tiffany, you talk about staff having to pay for parking. At the moment, we're not charging staff for parking on the Worcester site. I'd just like to clear that up. Because of the problems, we're not charging staff for their car parking on the Worcester site. We'll move on then. Thank you, Managing Directors. Thank you for your leadership. Thank you for your hard work. And in particular, I'd just like to share the point made about thank you to all of our frontline teams for coping with, we haven't mentioned, the industrial action and all of the other winter challenges over the last few weeks. And we'll move on then to the group analytics update, and Hack and Adam, over to you.
Okay, thank you, Russell. So in terms of group analytics update, we've continued to make progress with the group analytics programme since our last update, but not as much as we planned to due to lots of competing priorities, including some of the pressure that you've just heard about. I'll pull out some of the key elements from the report. So we've been working on developing capacity and capability of our informatics function, and you'll see some of the things that we've done within the report, so I won't go into that here. One of the key elements really is I think the group informatics forum that we've set up, which is an informal forum to enable our informatics colleagues to share good practice and ideas between them. We've also implemented Power BI, as you know, as an addition to our suite of reporting tools to give us access to the latest reporting technology. And the 4 organisations are at different stages with regards to developing reports and dashboards in Power BI. Now, developing these dashboards is kind of more challenging than we originally envisaged. So we are working on a plan of how we can do this more effectively across the group and get into a position where we can develop and deploy Power BI dashboards more quickly. We're also working on a process for sharing data across the group more easily. You've seen already the performance report that's included in the pack. That does require sharing a lot of data, and it's quite cumbersome at the moment. So the more easily we can share data, the easier it will be for in terms of managing the workload for the informatics functions. And it isn't just a performance report. A lot of the data within this meeting pack does come from informatics colleagues. So that data sharing is really important going forwards, and particularly when we're trying to improve services and learn from each other as well. And the final thing I wanted to draw out was the data quality kite marks work that we have been doing. So we applying the kite mark to the IPR metrics. There's about 120 metrics in the IPR integrated performance report dashboard for each of the organisations. Originally, we planned on completing that by the end of March. That's going to slip slightly to the end of June, but making reasonably good progress on that. Just wanted to draw out the addition of Worcestershire Acute to the group, and their informatics team in particular are a very welcome addition to the group analytics programme. They've very quickly become an active participant in the programme. They've already adopted the standardised integrated performance report we've got across the group. They've also adopted the group agreed data quality kite mark methodology as well. And they've showcased a number of great pieces of work that they've been doing around the information portal that they've got, and also their dynamic demand and capacity model. So, as I say, a really welcome addition to the group and really active participants in the work that we're doing. So, really kind of appreciate kind of how well and how quickly they've taken that on board. Just wanted to draw out the work we've been doing and looking ahead in the plan for the next few years. So we're 2 years into our 5-year group analytics strategy. So it's a good point for us to take stock and plan going forwards. So we've held 4 workshops. The latest one was yesterday, and we had a broad range of stakeholders there, which you can see set out in the report. And I'm really grateful for everybody who's made their time to come along to these workshops. It's really welcome, and getting that input is really helpful, and I particularly appreciate that considering all the pressures everybody's under. To date, the group analytics program has focused on some of the technical aspects of kind of what we do. We want to focus more on the softer skills, really, about how we develop an information-led culture. And you can see in the paper a definition that we've been developing, which will be the focus of our work going forwards, around how we have the right tools for the job, but how we develop our teams, not just our informatics team, but having well-informed, well-educated users of informatics as well, and that we use data to drive our decision making as well. So that's the focus of the planning going forwards. So we had a really good workshop yesterday, which discussed priorities for the group analytics programme. We're going to pull all that work together into a plan for the next few years, but we'll take that through the trust management boards for agreement, and then we can bring that back here and share it with this group as well. So in summary, we continue to make good progress, but with challenging competing priorities. And we're also making good progress on developing a plan for the next few years. And we're mindful of the EPI implementations across a number of group partners, and making sure that we incorporate that into our planning going forwards. So I'll stop there and take any comments or questions.
No, thank you, Hack. Adam, is there anything you want to add?
I think Hack's covered the key points. I mean, it's really good to have the four organisations working together in the group analytics function, and certainly adding Worcester, as Hack said, has added a new perspective and some new work. And we move now from the foundational work I think we've been doing over the few years to get our infrastructure, to get our data quality and so forth right, into some of that more cultural work, which will, I think, engage the organisations more. The only thing I'll add is, one of the conversations we had yesterday at the workshop actually was the role of the group analytics function in supporting driving productivity across the group, and I think that will become one of our priorities going forward. And I think there's a lot of good work we can do there. Just referencing Glenn's point earlier about sharing some of the learning between organisations, and I think we have a role in supporting with that.
No, thank you, Adam. So quick questions and perspectives, Richard.
Yeah, thanks, Adam and Hack as well. This is really key in the context of operational excellence. But what we've also seen is that in each of our change programs, we simply lack, let's say, capability because everybody is trying to utilize the same resources. So I'm asking, how can we, using this initiative, become more attractive, maybe get more outputs out of the entire group, so that we can support all of our change programs across the group better than what we've been able to do.
Okay, thank you, Richard. Adam, what would your perspective be on that?
I think that's a really good question. That's one of the things that we have been discussing, about how we utilise our collective skills and expertise, and what we've done quite a lot of work to try to understand what skills and expertise we have got across the group in terms of analytics. And the different organisations are different places and have got good practice in different areas. So I think there's something about how do we pull that together and actually do things once and share them across the group and use those skills as a singular team, rather than everybody trying to do their own thing. So I think we've got some really good skill sets across the group, but we're probably not. It's how we can bring it together into one place, and that's one of the things that we do need to crack going forward. And certainly a key part of the plan going forward will be exactly that: how we develop those recruit and retain the skill sets and develop additional those specialist skill sets, and then utilise those in the most effective way across the group.
Yeah, Glenn, do you want to come in? Thanks, Hack.
Yeah, thank you. And linked to that, Vicky Lewis at Worcestershire Acute is going to help to coordinate some of that work following the discussion that's reported later in the agenda at Group Strategy Committee. So there is an opportunity to strengthen the resilience of our teams, but also to use their capability to help us with productivity and service improvement. So that's something Vicky will be helping to take forward.
Thanks, Ben. Thanks, Richard. Thanks, Hack. Simon?
Thanks, both. Just a question on AI and robot process automation. I noticed in the report that it's not a priority for us at the moment. I guess there are capacity issues there. What are the implications of that? We run the risk of missing out. Perhaps you could just give us an idea of when we might be addressing it a little bit more full on. I know there's an AI steering group, but it was the reference in the report really to it not being top of the pile at the present.
Hack, do you want to handle this, or shall I pass it over to someone like Vicky?
If I can kind of start off, I think we've said for the last couple of years it's not been a priority because there's some of the basics that we're trying to sort out. Going forward, I think we do need to pick it up, but I think AI is broader than analytics. There's something about how we actually join it up with the digital agenda as well. So I think that's where it does, I think, cross over with some of the work that Vicky's been doing.
Yeah, no, agreed. Vicky, any
Yeah, thank you, Russell. So as Hack and Adam have both said, we did prioritise the work streams over the next 24 months, and AI set firmly out at between 18 and 24 months. In terms of the other piece of work I've been doing, it's part of the 6 frames and it's under that innovation frame. And I think, just as you've asked, Simon, I think AI means lots of different things to different people. So let's just standardise our terminology around that and what the expectation is. So it's part of the work that's going to come forward.
Thank you. And finally, Jackie, then we'll move on. Jackie?
Yes, thank you. I think it's picking up on a number of points that have been raised. So it's how do we sort of maximise the use of our resources and maximise productivity and minimise the risks around what is a very ambitious programme. And I think it's been covered quite well by the comments previously.
Okay. Glenn, is there anything you want to add? Because I guess it is one of the, going back to Richard's point about having not just resource, but competent resource in reasonably specialised roles. It is one of the strengths of the foundation group, is that we can identify talent in different places and pool talent.
Yeah, I mean, we use the word productivity and sometimes it can turn people off, but actually it's what we're here for, isn't it? Because we are given a considerable amount of public funding and it's our responsibility to deliver maximum patient benefit or public benefit from that. So the ability to drill down into the performance of each of our organisations and elements within our organisations gives us those nuggets of improvement that we can then look to roll out. And our approach is not about saying everyone must do it in the way that particular unit's doing. It's about saying go and have a look at it, see what the productivity improvements are that you can take back to your area, and then we benchmark and look for improvement. So this is absolutely vital in our next steps as a group and next steps as individual organisations, because there will be so much focus on getting delivering value, but also demonstrating. We touched on this morning with Lord Carter's presentation, demonstrating that we are using public funds effectively and we're delivering the maximum for our patients. So this is the absolute engine room of our quality and service improvement work. And I've been scratching my head over the last few days thinking about how we try and make sure that we bring all of that together, because we do have work on improvement, we do have work on cost improvement, we do have work on digital solutions to enhance some of that. So trying to make sure we draw all those threads together so that we're focused on the entire productivity opportunity is something that we'll be talking a bit more about as a board.
No, absolutely. Thank you, Glenn. And so we'll move on now then to the mutual aid for elective care patients and the deep dive undertaken by our chief operating officers. Colleagues, not sure how you want to divvy this up, but I'll pass it over to you.
Hello, so you've got me and Helen today presenting on behalf of the group. So Helen's going to share the slides and I'll just start talking through them. So as everyone knows, Post-COVID, waiting lists have increased quite substantially and recovery has been really challenging. As part of the answer to try and solve some of that recovery challenge, there's been a national push to facilitate mutual aid across systems and regions to try and bring down elective backlogs. And the way that we have approached this as a foundation group has been in collaboration. And by working together, I think you'll see that we perhaps found it quite a bit easier to facilitate and progress patients through. So at a very basic level, we have an operational group that meets monthly to discuss just wider issues. And we've been doing it for a while now, so Worcester were able to join that and rapidly integrate within that. But it means that we understand each other's priorities and can see what's on the horizon and where pinch points might be coming up to help each other plan. And the activity slide that is shared on the screen right now demonstrates some of the progress from that. So the offshoot from the operational group is a fortnightly mutual aid meeting where we talk in detail about which specialties need help and who can provide help and how might we best facilitate that. And that's the forum where we go through some of that detail. So the table outlines some of the support that's been delivered and what's already in negotiation. What it doesn't show is where we might have offered mutual aid outside of the group. And obviously that's a significant chunk of activity as well. But I think what it does demonstrate is that support is wide ranging and varied across the group in terms of the areas of capacity that people can provide for us. So in terms of some of the successes that we've had, I would say the processes are really a bit of a star of the show, really. Being able to meet so regularly and get to know one another and know what's on that horizon means that nothing has really been a surprise. Our members have been able to, the operational members of the group have been able to respond in quite a timely manner. They understand what the pinch points are, they understand what those profiles of waiting lists look like across each organisation, which just means that you can put in place a solution that's timely. And that's helped us to act really, really quickly. And time is of the essence with this. You know, these patients are on timed pathways, but also they've been on these pathways for a really long time. So reducing waiting times is key. And that would be the main success, I would say, of the whole approach. The patient benefit cannot be understated. These patients have been in pain and have been waiting for quite a long time. And each organisation has seen the phenomena where patients have been waiting for so long, they're then not fit for surgery by the time they get there, or they've presented it emergency departments to try and get support with their condition. So it's in everybody's interest to try and bring down some of these waiting lists. And the approach that we've taken has really brought about some of those benefits. Over to you, Helen.
Thank you, Harkamel. So what we wanted to do to demonstrate really that patient benefit was share a little news clipping with you, a news story, which clearly sets out the benefits of what Harkamel has just been talking through with you. So if we could just share that, and then we've just got one or two more slides after that, if that's okay with everybody. So just bear with me while we try and make the technology work. So let me know if you can't see this.
I
How's
had
that?
my pre-op.
Perfect.
And she said, now go to the office and you will be given a date. And that date was 2 weeks later. And I said, you're joking. How on earth can that be? And she said, yes, we've got the beds, we've got the staff. Don't worry, it will happen. And it did.
Shocked. They were just amazed. And obviously they bit your hand off at the chance of coming over and having their joint replaced. And some of them have waited 2 years, and the travelling was nothing to them. The minute that you say, you're going to be able to get yourself here, and that, oh yeah, of course I will, for the chance of having their operation done.
The South Warwickshire Accelerated Transfer Team, or SWAT, also makes sure that patients don't stay in hospital longer than necessary. Its complex but successful discharge programme is now being eyed up by larger NHS trusts across the Midlands.
Linking up between the pre-op team, the booking team, and then here on the ward, theatres. And the unique element that we have here at Warwick is we have an aftercare team called the SWAT team, which continues the patient's care even after they've gone home. So our length of stay is one of the lowest in the country.
All this means that staff here do work longer hours on occasions, but they say the results are more than worth the extra effort.
Yeah, it's extra work for me, but I'm
I'm just a little bit in the middle, and it's generated an awful lot of work for the pre-op team who see the patients before and get them ready for surgery, the ward staff, and then theatre space. And yeah, it's a tough ask. They're a great team and are working their socks off.
And every patient taken in from another trust means more income for Warwick, which helps to offset any extra costs.
By running it effectively and by ensuring the patient's in the right bed with the right team, we do very little extra premium activity. So we're not paying extra rates for it. We're doing it in the time that's in the consultant job plan. So it's our evidence shows that we get good outcomes, but we're also one of the most cost-effective providers in the NHS.
For once, this is an NHS good news story, thanks to the ingenuity of the South Warwickshire Foundation Trust. Swift by name, swift by nature. Andy Bevan, ITV News.
Thank you, Helen.
I'm just going to go through the last two slides, Russell, if that's okay, but you've got them in the papers.
Yes.
So as you can see, it's a real success story from a patient point of view, but also about how we use our resources across the group better and more effectively. I think the one thing we wanted to talk about really was the challenges, and so this isn't such an easy thing for us to do across the group. So the challenges really are split into three areas around patients, processes and workforce. And so for our patients, it's about making sure that we're providing consistent pre and post-op care, particularly if patients transfer mid-pathway. Our initial ability when we were working across the group is that we sort of dispatched the staff to the patient, so actually in that patient area. However, as our services are now busier, that's not really possible. And so that means that the patients then have to attend elsewhere, and that can either virtually or in person. And that can sometimes be quite a challenge for patients travelling across the county. There's a real issue for patients who are resident in Wales with a different commissioning base. And that's caused some issues, particularly from a Wye Valley point of view, about claiming the income from the Welsh system. And obviously I talked about patients, obviously they're not wanting to travel for their treatment, particularly if that's major surgery. And patients often citing the reason they didn't want to was because of the travelling. They don't want to be away from friends and relatives. And then it's the follow-up and the post-op care. So some of our processes, again, and the challenges that we've seen are around agreeing standardised clinical criteria for listing for surgery, and also the challenges that we've all equally got around delivering the 65-week and the 78-week wait. So that puts more pressure on capacity across all parts of the group. There's been some real administrative challenges around contacting patients and making sure that the paperwork is all complete and how we're transferring patients. So that goes without saying that that's taken a considerable amount of time for us to be able to do that. And then also about managing patient expectations. If once the mutual aid offer is there, then that becomes unsuccessful. And then again, we've talked about mutual aid really can be quite time consuming with small groups of staff or doing more work and currently on the large expectations of them at the moment. And so what's next for us? Because actually this is a success story and we do want to continue. So what's next? So that's really about how we start to look at harmonising our waiting lists across the group. And as our waiting lists continue to rise, again, that's about how do we manage that and start managing that more effectively at group level. We know that patients are often more conditioned while they're waiting. So really we need to start addressing that and trying to get patients seen as swiftly as possible across the group so that their deconditioning is lessened. And how we manage some of those evolving services. So there's some real innovation coming out across the group about how we're doing that. And so really how we spread and share and learn. We're continuing with our bi-weekly operational group and as Harkmel said, building those relationships and then understanding what each other's needs are has been really, really beneficial for all of the groups in terms of that shared learning and shared relationships. But also we want to explore the opportunities across the group now for post-op care. So can that post-op care and those follow-ups be done closer to the patient's home rather than the patient's travelling for that? Because that is one of the reasons why patients often don't want to travel. And I'm not going to go through and the other elements in there, but there's some lines within the presentation with the papers around some of our real opportunities that we're starting to see moving forward. And the slide deck of the papers didn't actually include some of the mutual aid that we're already providing, which is haematology and stroke within that as well. So there's lots and lots going on, really exciting opportunity, and some real benefits for all teams. So we'll just end there, Russell, and if there's any questions.
Right. Thank you to all of the Chief Operating Officers and Chief Medical Officers and Chief Nursing Officers for the work you're putting in to make this happen. It makes a real difference to our patients and citizens that we serve. Questions or perspectives? Glenn?
Yeah, and it's really good to see the list at the end there with the reciprocation between the organisations of addressing the backlogs in waiting time. And I think it's important for us to concentrate on the fact that this is dealing with backlogs. I mean, ultimately, we would like to see a situation where each individual organisation is optimising its capacity, and therefore we're not asking patients to choose to travel, because, as Helen said, they will often decline an offer to travel elsewhere. So there's a question for the Chief Operating Officers about how we try to make sure at the end of this, when we dealt with the backlog, that we've got the right capacity in each organisation to deal with its local catchment volumes.
Yeah, I guess that's it's a rhetorical question, isn't it, Glenn?
Yeah, I mean, I don't expect a worked up answer now, but I think the challenge is to make sure that that's what we do. And indeed, in each individual organisation, have the ability to flex between specialties so that we keep that care local.
Yeah, no, absolutely. Local is best, but this is, if we can't do that, this is a great next step. Conscious of the time, Francis?
Thank you. Just on the patients being reluctant to travel, I think one of the benefits of having surgery so much more quickly than they'll be able to in their local hospital, and I just encourage us to work with our local community organisations to look at some supporting patients and their families with transport solutions, because that can be one of the limiting factors, and I think we'll have opportunities to do that to increase the uptake.
Yeah, I mean, there's an important point made in the chat box around health inequalities and income inequalities and the challenges that leads to in terms of ability to travel, which we need to make sure we are appropriately understanding. Okay, team, really great work, really good news item. Let's make sure we do lots of it until we're in a much better place. We'll move on then to the safe staffing overview to include the nurse bed ratio. Over to my CNOs. Not sure who's leading off on this.
It's myself, Russell. Okay, so I'm not going to share the presentation because obviously you've all read it, but as chief nurses, we've been working together over the last few months to standardise what we feel are the key performance indicators around safe staffing, and to standardise the format in the way that we present across the 4 trusts. We have tried to standardise as much as we can, but you will note in the quality indicator section that one trust is reporting per 1,000 bed days around harm. We will change that so that all of the 4 trusts are reported in that way for the next time. So each CNO will now just give a very brief exception update on their part of the scorecard. So I think I'm handing to Fiona first.
Yeah, thanks, Sarah. So just briefly, really, the things that drive the staffing usage at Swift, similar to the other organisations, is the escalation beds that we're in and have been over the last 3 months. So on average, that's been 20 beds, which has created pressure on staffing. The other is the high acuity of patients, and we've already heard that reflected in our operational reports in terms of the demand in A&E and the emergency flow. So those patients are particularly sick and complex and have required additional staffing at times. So the drivers for that particularly have been the mental health patients that often need to stay in acute beds because of the lack of tier 3 mental health provision, both in adults and children. And we're working obviously with our system colleagues and mental health providers to work through those pathways. The other is a higher than normal vacancies, particularly at Swift in paediatric nursing. And again, we're working through trying to find solutions to that. We have seen a reduction in spend in agency costs for nurse staffing, and that's been due to the hard work we've been doing around retention and recruitment, but also challenging that the use of agency nurses. That's beneficial to patients to provide continuity of care, but also obviously a financial improvement as well. We haven't seen any reduction, any correlation in the harm related to unsafe staffing, which again is reassuring to ourselves and hopefully the public. Just to reassure the public that the more detailed reports are reported into our organisational board reports, and that is more. That includes not only staffing in the acute, which is what this focus is, but also other professions and out of hospital staffing as well. Happy to take questions at the end. Thank you.
Where do we go now, Fiona?
It's me. I think it's Lucy from Wye Valley. So just some key headlines from me, not dissimilar to what I think you'll hear from each of us as we go through. So at Wye Valley, yes, we're achieving safe staffing levels, but not at best value for money and certainly not at best quality. The reason for that being that we still remain heavily reliant on agency staff and temporary workforce to provide the number of staff that we need to keep our patients safe. That heavy agency reliance is largely because although we're showing a really strong vacancy position in terms of low numbers of vacancies for registered nurses and healthcare support workers, that's been masked by the fact that our budgets and our establishments just don't align. So for example, we're having to put an additional 28 whole-time equivalents into our emergency department to keep the patients safe. And we have Gilwyn, which is a 16-bedded ward that's unfunded that we haven't closed in the last 2 years, that drives some of that temporary workforce. In addition to that, it's around extra beds, boarding patients, high sickness, and as I say, the patient safety that I've just described within the emergency department. So if we use today as a typical example, just to illustrate why we're so heavily reliant on agency and temporary workforce, we have 15 patients in our day case unit overnight, every night, and have done throughout the whole of the winter period and on a weekend, every single weekend. There's no budget for that, there's no establishment for that, so we have to rely on high cost agency to cover that. We have 33 boarding patients in our bed base today. Remember, we're the smallest of the 4 trusts. We only have 11 wards and there are 33 boarders. Today is not unusual, that's 33. We've had the high 20s for the whole of this week. We had 16 patients waiting for a bed in our emergency department this morning and no beds to move them into. And on top of that, we had 27 additional beds open that don't have funding. So you can see we're not far short of 100 additional patients that are in unfunded beds that we have to provide safe staffing for. So as I say, we're achieving that, but we're achieving that in a very expensive way and not always through the best quality. Our sickness levels, as you can see, are broadly comparable across the group. But when you look at the headroom that we build in for healthcare support workers, we only build in 18%. For the public, headroom is what you put into your budgets and your establishments to enable you to be able to consistently staff your areas despite staff being either on sick leave, annual leave, study leave or maternity leave. So when you see high sick levels and a low headroom, you will drive high reliance on temporary workforce to cover the gaps to maintain that workforce. And 18% is woefully short. If we did the minimum end of headroom that's recommended nationally, which is the minimum end's 22%, that would be an additional 33 whole-time equivalents that we could add to our healthcare support worker workforce and reduce reliance on temporary workforce. That said, we took a paper to our Trust Management Board recently to say, let's align our budgets to our establishments where it's appropriate and sensible to do so, and let's recruit substantively where it's sensible and appropriate to do so to reduce that reliance and improve the quality and value for money. Happy to take any questions at the end. And I think I'm moving on to Natalie.
Thank you, Lucy.
Thank you, Lucy. Oh, sorry, thank you. Okay, so as my two colleagues have already said, all of us have extra patients in our bed base over and above our planned and establishment at the moment for the George Eliot. On average, over the 3 months in the paper, you can see that's about 32 extra patients a day. And that means that on a week's basis, we're looking at an extra 28 and whole-time equivalent registered nurses and roughly about 14 healthcare support workers. That being said, although our vacancy rate in the paper is still not where we want it to be, it is a huge improvement, and we have made those improvements over the past 12 months and reduced our percentage, and we are still doing that. And in the paper it outlines how we're doing that from both domestic and international recruitment, and we have had successes in both of those. It's now about retention and making sure that we retain those staff, and it has meant that we have been able to quite considerably reduce the amount of agency staff that we have been using across the board. And it means that we have not had to use off framework, which is the real high expensive agency, since July. Our specialist areas are the areas where we use the most of our agency workers, and we are going out and continuing to champion coming to work in those areas. We do consider the staffing levels in each and every incident that is reported, be there the nurse sensitive indicators, and we may ensure that we are looking at this on a daily basis or whenever it happens within the organisation, and we have a morning huddle and we discuss any harm that has taken place. You'll note in the dashboard that our care hours per patient day is still the lowest, and that is, we're improving that with the recruitment, but based on the number of beds that we do have open and the patients that we're caring for, actually our harm levels, I'm pleased to say, are not at the moment correlating to that staffing level, and we are working hard to increase that. And I am handing over to Sarah.
Natalie. So much the same around the pressures around boarding patients and additional beds being open. I am pleased to say that we are seeing a reducing month-on-month vacancy rate, which is something we've worked really hard at, and we'll be looking at what Lucy is doing in Wye Valley to have such low vacancy numbers. We are seeing a reduction in our agency spend, but an increase in our bank spend, which is obviously where we want to be. We are pleased with not having any falls with harm, and where our harm indicators are at the moment. Again, a lot of work has been going into these areas. An area of focus over the next 4 to 6 weeks is around our nurse to bed ratios. Now, we are thinking a lot of this is driven by some of our smaller wards, where our wards are either 1 in 15 beds, 17 beds, and the 1:8 nurse to patient ratio that we apply. So we're just doing a piece of work now around looking at our registered nurse associates and whether we actually do some skill mix reviews, so that work's ongoing. So apart from that, I will stop there, Russell, and any others are happy to take any questions.
No, thank you, all four colleagues, for your comprehensive updates. Lots of challenges, we know, but great to see generally the agency the usage going down. Questions or perspectives, Glenn?
Yeah, I hope the chief nursing officers found this dashboard as fascinating as I do, actually, in terms of when you look at the comparisons across the organisations. I think it would be useful to separate bank from agency, because generally bank is something that you manage your rotas around in a good way, rather than agency being something we want to avoid. I do worry about the safer staffing tool, because I think it potentially has this inbuilt growth model. Every time you look at the acuity of patients, it determines that you need more staff. It actually doesn't take account of the experience of staff, which I think is a more important factor sometimes than the sheer numbers. But I think it does take us to that question, which I think Lucy touched on, of in some areas where we've got really quite low vacancy levels, but we are always needing to have additional staff to open extra areas, as to whether we're kidding ourselves with a low budget and therefore incurring higher costs than we would have otherwise done if we were recruiting to that higher budget. So I think there's just something about a sensible pool of nurses that allows us to flex that capacity, because we always will need to, which would be better value than doing it at last minute through agency.
Can I ask Lucy and Sarah's hands have gone up to put their comments in the chat box for me. Catherine?
Yes, I think this is a very helpful slide as well. Natalie, my question to you is, when you look at that data, despite having the highest vacancy rates and the lowest care hour per patient days, we've also got the lowest incidence or red flags. Is that underreporting? Is that we're doing something well? How should we interpret that?
And Natalie?
Thank you. I think it's a bit of a mixture, Catherine, because I asked them to run that data 2 or 3 times for me, particularly for November and December, because they did see very low. I think in part sometimes it's, particularly when it's staffing related, do we always report it via Datix, which is where this data comes from? If we ran it in correlation with harms, etc., now our falls with harm are very low, I'm pleased to say, and our hospital acquired pressure ulcers, although not where I want them to be, are also coming down. I think that is in the main, Catherine, because of our success with recruitment and our international nurses now coming into the numbers. So I think we are seeing improvements. I think the numbers of red flags and incidents are coming down, but I do think that November and December data is probably a bit too low. And I think that's a mixture of not reporting as much as we should have done.
Always best to reopen, Natalie. Well done. Thank you. Thank you, Catherine. Thank you for comments being put into the chat box. OK, team, this is Race Equality Week. And so we'll move on then to the equality update and the NHS Equality Delivery Scheme, EDS 2022. Gertie and Tina and Jeffrey. But just before we go there, this is Tina's last board with us. So Tina, I want to thank you publicly for the phenomenal efforts you put in for a number of years. We will miss you, but we all wish you very well in your new endeavours. But who's leading off on this team?
I am, Russell, on behalf of all of us. So I will be quite brief. The paper sets it out. So I will start off with the Equality Delivery System, or EDS2. It's well known to us in the NHS. We've had it since 2011, and it's been updated a couple of times, most recently in 2022, and it's essentially an improvement framework or a system for NHS trusts to improve our services, both for our patients and for our staff, to create an open, inclusive culture, meeting our obligations under the Equality Act 2010 and the public sector equality duty. There are 11 outcomes across 3 domains that we were required to review, and we will be all required to publish from March this year, which was commissioned or provision services, workforce health and wellbeing, and inclusive leadership. As I said, EDS 22 is an improvement tool. It's set out with some very specific guidance that we should have key stakeholder groups with a wide variety of people inputting to that, from public, the patients, our staff network, our trade unions, HR professionals, and that you had external colleagues from other organisations. That piece of work has been undertaken in each of our organisations, and we followed the set scoring. The table in section 3 of the paper included provides a summary of the scores by each organisation. And what's really positive to see is that there are no areas across the foundation group where we see undeveloped activity against the equality delivery system, and then we do have a range of developing, achieving, excelling. And again, as we've seen in many of the conversations we've had today throughout the Foundation 4 Group Board, there's plenty of opportunity from that for us to share learning, share experience, share information to support each other in improving our equality systems within each of our organisation. We are now looking at developing action plans, and again we'll look at what areas we can maximise the benefit of the group by sharing that to be more productive in terms of how we can manage that activity. There was a very detailed set of assessments done which span to about 42 to 43 pages per organisation, which we've obviously not included here because it's a huge level of detail, but I would like to give assurance to the public and our boards that that has been detailed and undertaken. Jeffrey, Tina, myself are very happy to take any questions. Thank you, Russell.
Thank you, Gertie. Any questions or perspectives to the CPOs? Sue Whelan-Tracy?
Yeah, thanks, Gertie. Thanks for bringing this up to this level and to all the work that goes on underneath it. I just wondered under number 1, the commissioned and provided services, what assurance is there that we're not self-selecting services where we know we're good at this? I just want to make sure that we're not excluding communities and service users who are often ignored.
Thank you, Sue. Yeah, I mean, it's a fantastic question. I mean, each of the areas predominantly, I can answer on behalf of George Eliot and South Warwickshire. We looked at maternity services in these aspects because it did cover both acute and community in terms of the service provision. We do have to review these year on year, and the expectation is that you would expand out to include different elements. The majority of organisations in our national conversations are looking at maternity in the first instance, following on from the Ockenden review and in light of the reviews of maternity services. But the expectation will be that we continue to expand this review year on year, so we wouldn't miss those.
Okay, I'm just keeping the pace going. I'm going to ask Uma to put his comment into the chat box. Jane?
Similar theme, because I was quite surprised when I saw how far behind Wye Valley were, and I'm wondering if it's about which services were selected or whether the criteria and threshold have been applied in the same way. I mean, I don't know if maternity was in ours, but I'd be surprised if it was very different to the others, given all the things we know about the quality of our community services. So, our maternity services. So I guess really it's a question for outside to say about, are we applying those thresholds and criteria in the same way? And we may be, but I was just a bit surprised at the data.
Okay, can I ask you to take that away, please, Jane, and follow it up? Stephen?
Yeah, it's kind of similar, I guess. It would be really helpful to see this develop where we can almost get a peer network of cross-checking each other, because this is one area where it will be really easy to have an inbuilt bias towards your own service and team, wouldn't it? So I think just if we could do that, that'd be really good.
Yeah. Okay, any other comments from colleagues? Happy to move on. So I think then we're on to some items for approval, and the first is the Foundation Group Board schedule of business, which I will take as read. Any questions from colleagues? Okay, if you're not happy to approve this, could you please raise a digital hand? It will obviously evolve just as the world evolves with us. Okay, super, duly approved. And then we've got the Foundation Group Strategy Committee annual report, which again I will take as read. Obviously, a very interesting year with the joining into the group of the Worcestershire Acute Hospital Trust. Any questions on that annual report? Okay, it's just for noting. And then we've got the Foundation Group Strategy Committee report from the meeting which occurred on the 16th of January. As Glenn indicated, we did talk about a group job planning with David Mowbray a voice from the past came to visit us, and has been doing some very good work on job planning, but lots of opportunities still there for us. And then the talk about how we move forward on a group digital data and technology scope proposal, which Vicky is intimately involved in. And then we talked about some other stuff. Any questions on that meeting? Anything you particularly wanted to add, Glenn, just to...
No, I mean, you pulled out two of the most important ones. I actually do think the consistency around job planning, the approach to job planning amongst teams of clinicians, but also using capacity and demand modelling is going to be such an important element of that productivity improvement, but also tackling things like waiting list backlog. So that's a really important piece of work.
Yeah, and we did talk, and I'll just leave this with the MDs in particular and our strategy directors about the importance of sharing this data down the organisation so that everyone knows what the comparisons are showing out of the foundation group, just to illuminate all colleagues. So I think we're then on to any other business. So board members, any other business, please raise a digital hand. I can't see any digital hands raised. Thank you. So I'm aware of a couple of questions from members of the public. Erica, would you be so kind as to read out Roger Lloyd's question for me, please?
Yes, Chair. Is it considered appropriate for there to be more executives appointed jointly to different trusts to develop more group actions? Or is the appointment of executives to single trusts the best way to deliver improvements in each of the group trusts?
Okay, Glenn, do you want to answer that one?
Yeah, that's something I talked about in the podcast you referred to earlier. I think one of the important elements of our model, and there are different group models elsewhere in the NHS, is the sovereignty of each individual board, and linked to that for me the accountability of particularly the exec directors within those individual boards. So I would never want a situation where any challenge or issue is being handled by someone in a potentially remote group role. So we've generally stuck to the principle of individual executive directors in each individual board. Where we do have group level roles, they are advisory, and they're advising those individual accountable execs in each organisation, and I think that's an important model. From time to time, individual execs will lead on something on behalf of the group, but the accountability for that still rests with the execs in each boardroom. And I think we get therefore the best balance of using the scale and the skills of people around this gallery, but also keeping that local accountability, and importantly for me, that ability to respond to the needs of each place in which we operate and to work with partners at place, as opposed to suggesting that that's a kind of remote thing that group does. So hopefully we've got the balance right on that. We're not perfect. I keep looking at group models elsewhere to see if we can learn from them, and no doubt we'll make further refinements, but I think that's an important principle to stick to.
No, thank you very much, Glenn, and I wholeheartedly agree. And any other questions that we've been informed of, Erica? Otherwise, I'll just invite members of the public to ask anything they'd like.
No questions, Chair.
Okay, thank you. So, members of the public, are there any questions you'd like to ask? I've had a hand go up, just bear with me. And I've had a hand go down. Any questions from members of the public? Okay, I'll draw the meeting to a close then with enormous thanks to all of the frontline teams who day in, day out have been coping with the challenges, like we said, of winter and the industrial action. I'd like to thank all of the executive directors. I know the phenomenal hard work you have to put up with, being on call overnight on occasion, working weekends, texts from various different members of the region, let alone the group, and the occasional comment from me about what's going on at Shrewd. I really do appreciate how hard you all work to try and look after our patients. Tina, you leave with our love. And I'd like to apologise, as I think Jane did, or Catherine did in her introduction, to members of the public. We are still not performing as well as we want to and as well as we aspire to, but we are relentless as a group of individuals to make sure that we do deliver the level of healthcare service you require. We would say, though, or I would say, there's a quid pro quo to this. We do need you to try and look after yourself. Try and move a bit more. Try and look after yourself in terms of what you eat. Try and look after members of your community who may be lonely. Recognise that hospital is not always best. That being at home can often be the better place for you to get the health improvement you're looking for. Do consider other options than A&E. Our A&Es are incredibly busy. A very high percentage of people who come to our A&E do not need to be admitted into the hospital. So if you can find other ways of accessing healthcare, please do so and help the very hard-working A&E and hospital teams that we have. Take care, members of the public. Look forward to seeing you in the individual boards next month. For board colleagues, I will see you at 3:15 in the confidential board, so we can all grab a quick cup of tea. Thank you very much, everyone. Take care.
Thank you.